Hi, this is Dr. Lauderbach, and this is the Genetics and Genomics lecture for the Advanced Practice Assessment course. This lecture will follow the Goolsbee and Grubbs textbook Chapter 3 with additional information from other sources that are available in the course module for Week 11. Outcomes for this lecture are for students to understand basic human genetics and genomics, to describe the benefits and role of family history in advanced health assessment, to conduct a genetic risk assessment, performing a genetic family history and pedigree, to identify threats and hazards from environmental exposures, and to estimate the probability of risk. Also, to discuss common genetic and genomic testing options, to discuss the genetic influences on health, and to discuss implications for advanced practice. As we begin, it's worthwhile to talk about what is the difference, or what is genetics and what is genomics. This slide shows a definition of genetics, which is a term that refers to the study of genes and their role in inheritance, the way certain traits are passed down from one generation to another. Genomics is defined as the study of a person's genetic material and the interactions of that genetic material with the individual and with the environment, and the subsequent phenotypic changes that result from the interactions of those components. Simply put, genetics uses information from one or two genes to explain a disease or condition, whereas genomics examines all of an individual's genetic information to determine biological markers which are predisposing the individual to disease. So let's take a moment as we begin to talk about genetics and chromosomes, the basics. So we know that all of inheritance comes to us through deoxyribonucleic acid, or DNA, which is formed into structures called chromosomes. And here we see a picture of an X chromosome. And this information is carried forward to the progeny of an organism, in this case humans, by replication of the genetic information found on the chromosome. Here are some common terms in alphabetical order, and this is a table right out of the Goolsbee and Grubbs text. The affected person is the individual who manifests the disorder. An allele is one version of a gene at a given point along a chromosome. Consanguinity is related in descent by a common ancestor. So in a pedigree, we'll see that with double lines connecting people who have a common ancestor. De novo mutations are new spontaneous or non-inherited mutations. They're alterations in a gene resulting from a germ cell mutation present for the first time in a family member. Expressivity of a variable is the range of clinical features observed in individuals with a particular disorder. Variable expressivity applies to disorders following all patterns of inheritance. Genes are the functional and physical unit of heredity passed from parent to offspring, and there are approximately 20 to 25,000 genes in the cell of humans. Genetics is the study of heredity, the process in which parent passes certain genes onto their children, and how particular qualities or traits are transmitted from parents to offspring. The study of single genes and their effects, that's genetics. A person's appearance, such as their weight, their hair color, their skin color, their eye color, are determined by genes. Other characteristics, such as mental abilities, natural talents, and susceptibility to develop certain diseases, can also be affected by heredity. The genome is all the DNA contained in an organism or a cell, which includes both the chromosomes within the nucleus and the DNA in the mitochondria. Genomics is the study of functions and interactions of all the genes in the genome. Mutation is a permanent structural alteration in DNA. In most cases, DNA changes either have no effect or cause harm, but occasionally a mutation can improve an organism's chance of surviving and passing the beneficial change on to its descendants. A pedigree is a graphic illustration of the family health history using standardized symbols, a genetic representation of a family tree that diagrams inheritance of a trait or disease through several generations and shows relationships between members of the family. Penetrance is the proportion of individuals with a mutation causing a particular disorder who exhibit clinical symptoms of that disorder. A phenotype is the observable traits or characteristics that result from having a particular gene. A proband is the affected individual by whom a family with a genetic disorder is ascertained. So here are some definitions and characteristics of single gene patterns of inheritance. So this is the Mendelian genetical inheritance that we all learned starting in biology, probably in high school. But they form different types of categories based on what kinds of chromosomes are involved and whether the genes are dominant or recessive. So there's autosomal dominant, and in this case, a gene on one of the autosomes. So an autosome is a non-sex chromosome. A gene on one of the autosomes that may be expressed even if only one copy is present. That's a dominant gene, even if only one copy is present. 50% chance of parental transmission. Males and females are affected equally because this is autosomal. The phenotype is observed in multiple or every generation with which the affected person having an affected parent, or that is to say there's a vertical transmission on the pedigree. There are some exceptions, and they may be de novo variable expressivity, the penetrance in the family structure, early onset of deaths, and conditions related to sex assigned at birth, such as breast and ovarian cancer syndromes, may not be observed in families with limited or small number of females. So that's for the autosomal dominant. Autosomal recessive is a genetic disorder that appears only in a patient who has received 2 copies of a gene mutation, one from each parent. 2 genetic mutations on the autosomes. 50% chance of the offspring inheriting 1 gene mutation carrier, 25% chance of inheriting the disease or phenotype. There's horizontal transmission on the pedigree proband, and it may affect siblings, none in the parents who are carriers. Offspring or other relatives, males and females, are affected equally. Again, this is autosomal. So, X-linked dominant genetic mutations are ones that are located on the X chromosome and requires only 1 copy for phenotype or disease to appear in males or females. You will probably recall from just prior basic science study that the Y chromosome really carries essentially no genetic information other than determining the sex of the individual. So that's why we don't have any Y-linked dominant or Y-linked recessive diseases, because the Y just doesn't carry much. It just designates males. X-linked, the X chromosome carries the full genome. And so we're really determining, is it X, or is it dominant or recessive? And these are the sex-linked diseases. So we said the dominant is you only have to have 1 copy of the phenotype. So in a female offspring, there would be 2 X chromosomes, 1 from the mother. And it is enough for that to happen to create the disease. In X-linked recessives, the genetic mutation located on the X chromosome requires both chromosomes to be affected in females. Males with the affected gene will have the disorder. So in females who receive 1 X from the mother and 1 X from the father, they will be carriers, but they won't have the disease. In males who only have an X, one X chromosome instead of two, they get their X chromosome from their mother. They don't get an X from their father, and they're male because they have an X and a Y, and they will have the disorder. So you see this, the most common one I think that we hear about is hemophilia, classical hemophilia A and B. Typically males are affected, rare in females with transmission from the mother carrier. 50% of the males will inherit the gene from their father and are unaffected carriers. There is no male-to-male transmission for the reasons we already discussed. There also is mitochondrial DNA, and these are within the mitochondria, not in the nucleus, and these mutations are located in its own DNA because the mitochondria carry their own DNA, and it has to be inherited by the mother. All offspring of affected females and none of the offspring of affected males will happen. And the reason is that when an X and a Y come together to form a zygote, the Y doesn't carry anything but basic genetic information. It doesn't carry only nuclear information, I should say. Whereas the Y carries the cytoplasmic information, which includes the mitochondria and the mitochondrial DNA. So here are some graphic depictions of the information we just talked about. This is an autosomal dominant with 2 affected offspring due to dominance and 2 normals and no carriers. This is autosomal dominant, non-sex linked autosomal dominant. This is autosomal recessive. Again, autosomal, not sex linked, but in order to be affected, the child has to have defective genes from both mother and father because it's recessive. They both have to be present. So they are going to have, the father is a carrier with an affected and unaffected gene, and the mother is a carrier with an unaffected and affected gene, and when they cross, they will have an unaffected son, a carrier daughter, a carrier son, and an affected daughter. Here we see X-linked transmission, where we have a carrier mother and a normal father. So that cross gives you a normal male, a normal female, an affected male, and a carrier female because it's X-linked. The son, the affected male, only got genes from the mother, who was a carrier, because the Y doesn't carry any information. So these in the sex-linked groups will produce this kind of a cross. With a very quick review of basic genetics, we will move our interest in genetics and genomics in this assessment course to focus on conducting a genomics risk assessment as part of a comprehensive health assessment. The risk assessment is part of a comprehensive health assessment, which includes a physical exam, health history, symptoms that they may be having, and a comprehensive family health assessment. The risk assessment process takes into account all known relevant factors to determine the probability of developing a disease, both common chronic illnesses and genetic and genomic disorders. It might involve genetic or genomic testing, phenotypic evaluation, physiological, biological, such as race and ethnicity, behavioral, psychosocial, and environmental factors. The role of the nurse practitioner in genetics practice is to identify individuals who may benefit from genetic counseling and testing services, recognize physical and historical features of genetic disorders in the individual, provide basic genetic information and counseling to facilitate informed decision-making and informed consent for genetic testing and other genetic services, and to know the full range of genetic specialists available in that NP's area of practice, geographical area of practice, and when a referral or collaboration is indicated, and then collaborating with genetic specialists in managing patients with complex and rare genetic disorders. When thinking about how to do a genetic or genomic risk assessment, you need a process. So here's one model. Comes from a book you don't have, but that I used as a reference, from Edwards and Meredeghi. And they have this four-step model to review thoroughly, assess the health history and physical exam data, to identify red flags, and we'll be coming back to discuss what red flags are a little later on, to select the probability of risk based on the identified red flags, and then to keep the patient informed by risk communication and risk management. In the next slide, you'll see the one that the book presents, called Rapid Risk Assessment Using Probability and Identification Through Data Collection. It's pretty much the same model, a little more detail here. So the first part is data collection, and it's a personal history, a physical assessment, the family history with 3 generations to form the pedigree, environmental, laboratory ancillary, and genetics data. 2 is identifying threats and hazards. For example, has the individual been involved in biological or genetics threats or behaviors? Do they have those? Is there threats coming from the home environment, the hospital or occupational environments? And are there any red flags indicating high risk or a single gene disorder? From that, you will develop a probability estimate, and that can be both quantitative and qualitative. The quantitative, we would use empirical risk assessment tools, and there are examples, I should say links to tools that you can use online to determine that. And also there's a more qualitative approach where they are categorical and non-numeric. And then based on the risk assessment, the NP would communicate and manage the risk through enhanced surveillance, prevention strategies, chemoprevention, and risk reduction surgery. So let's talk about the family history. The family health history is really the very first genetic test you do. Families share genetic, environmental, cultural, and behavioral factors that may influence their risk for many health conditions. There's common chronic diseases that have a genetic transmission significance. Mendelian and chromosome, Mendelian means the basic genetic replication that happens in reproduction, and chromosome disorders that get transferred. I will take this moment to tell you, we are not going to talk about epigenetics. Epigenetics actually are heritable changes, meaning they're inherited in the way genes are expressed, but the genes themselves do not change. It's a separate area that is important, and in many ways we may be looking at it. They're heritable. That word means they're inherited, but if you did a genome analysis of the individuals, you would not find specific genetic mutations. So they aren't that kind of a mutation, but there are things that control or modify how genes are read, how they're transcribed. There are three methods that this can be changed. I'm not going to go into that. That's a study of epigenetics. But it's important to know that some of the things we see may be epigenetic changes rather than real genetic changes. An example might be obesity. We know that there is a genetic relationship between generations on obesity, and it's certainly multifactorial. But one of the things we know is that foods that the mother's eating while pregnant can create changes in the structures, the ribosomes that read the genetic code that is passed on to future generations and predispose them to have certain genes not transcribed, that is to say, not expressed, that leads to obesity. That's all I'm going to say about it. It's certainly nothing I'm going to test you on. But know that there is a whole area we're not going to even touch on here called epigenetics. Okay. So, common chronic diseases, Mendelian and chromosomal disorders, known exposures to mutagens, and that's kind of why the epigenetic thing came up to my mind. We're just talking about changes, actually changes to the genome here. What are mutagens? Well, mutagens are things that cause mutation, permanent changes to the chromosome that then gets replicated and passed on to the progeny. Think of one current example. If you have anything on the television or the radio, listening to the media of any kind, you're going to hear lawyers basically encouraging people to call them to see if they qualify for benefits under Camp Lejeune water exposures. Well, Camp Lejeune was in North Carolina. It may still be there, but at a period of time, about 40 years ago, the water became contaminated with trichloroethylene, perchloroethylene, benzene, and vinyl chloride. All of these are known to be mutagens. So now we see, not only in the people who were exposed, but now in their progeny and their kids, certain disease patterns that are related to those exposures. There are other types of environmental mutagens too: industrial chemicals, pesticides, herbicides, heavy metals, and some are listed here. Some drugs and endocrine disruptors, BPA. Whether you would ask people if you know in your family, have your folks or siblings or anybody else, not generally siblings aren't going to be of interest, but more parents, grandparents, known exposures to radiation or, Agent Orange or any of that sort of thing. Agent Orange was a herbicide used in the Vietnam War, which mostly contained, the problem with it is it had dioxin in it, and that mutated chromosomes of the soldiers, which then gets replicated, passed on to their kids, causing cancers and other problems. That's the kind of thing you'd be asking about, kind of generally asking about that in a primary care interview. So what about common chronic diseases like cardiovascular disease, certain types of endocrine disorders? They all have multifactorial inheritance. The family health history is an established risk factor for common chronic disease, and that gets incorporated into the screening guidelines. So if you're taking the history, you would know that a first-degree relative has a 2 to 5% increased risk. And we see this in breast cancer, ovarian cancers, different things. With multiple relatives, it may be greater than a 5-time risk. And then we also want to know about modifiable risk factors. Smoking, obesity, that sort of thing. So who do you want to talk to? Who do you want to know about when you're doing the family health history genetics? 3 generations. That's important to remember. 3 generations. Non-living and living relatives. And you need to specify the relationships. Adopted versus biological, half versus full siblings, because that goes into the pedigree. The things you're going to ask when you're doing the patient assessments. The basic things is their sex, their current age, the sex of your mother, your father, your grandmother, your grandfather, paternal and maternal, current age or if deceased, when did they die and what was their cause of death, what were their diagnoses, at what age did they get the diagnosis, and did they have any environmental exposures that you know of or any peculiar lifestyle factors that might account for, say, a premature death. into more detail, here are some more things you'd want to know about. Known genetic conditions, family cancers, abnormal newborn screening results, birth defects, intellectual disabilities, developmental delays, or individuals who have been diagnosed on the autism spectrum, mental health, stillbirth, sudden infant death and early death, recurrent miscarriage, neuromuscular conditions like muscular dystrophy or Huntington's chorea, early hearing or vision loss, very tall or very short stature, blood disorders like hemoglobinopathies, hemophilias, von Willebrand's, clotting disorders, and so forth, bone and skin abnormalities, deformities, peculiar birthmarks, common chronic disease, and their ancestry or their ethnicity. In a typical primary care assessment, you might not ask all of these questions, but you would if there were red flags were identified during the routine family history, and we will look at red flags in a slide that's coming up. This mnemonic screen is a helpful trigger to kind of remember what do you want to talk about when you're doing this family history. SC in the first two letters of screen, some concerns, which is simply a broad question. Do you have any concerns about diseases or conditions that run in your family? Reproduction. Have there been any problems with pregnancy, infertility, or birth defects in your family? Because that indicates there may be some genetic inheritance mutations that have caused fetal deaths and infertility or birth defects. You'll spot it when you're doing the history, and have there been a lot of birth defects or infertility? Have there been any? And then you would make the determination, is that a lot or kind of the baseline to be expected in the population. Early disease, death, or disability, again, can be genetically related. Ethnicity. We know that there are certain diseases that are carried in the genomes of people of particular areas, like thalassemia among Mediterranean people and so forth. And then non-genetic things. Are there any other risk factors or non-medical conditions that run in your family? So this is a busy slide, and it comes right out of the textbook, so you can refer back to this by looking in your Goolsby and Grubbs book. But it really breaks out nicely what are red flags when you're taking that history. Early onset problems, in particular breast cancer, colon cancer, and cardiovascular illness. Occurrence of cancer in the less often affected sex, like breast cancer in a man. Multiple family members with a cancer, especially if the age of onset is earlier than usual. Any autosomal dominant pattern of inheritance. Known hereditary cancer mutations, like I know my mother had breast cancer and she had a BRCA1 and BRCA2 mutation. Family member with multiple primary cancers, clustering of syndromes associated with a hereditary disorder. Examples given here. 2 or more unusual cancers in the same person or close relative. Then medical disorders. Heart disease before 40 to 50 years old, dementia before 60, hearing loss before the age of 50 to 60, 3 or more pregnancy losses, several family members with the same condition, and multisystem bilateral or multisystem occurrences such as deafness or nephritis, suggesting of things like Alport syndrome. Then in this mnemonic, family genes. G is group of congenital anomalies. E is extreme or exceptional presentation of common conditions. And the example they give here is multiple primary cancers seen with hereditary cancer syndromes such as BRCA mutation. N is for neurological delays or degeneration. E is for extreme or exceptional pathology, and S is for surprising laboratory values like familial hypercholesterolemia. Other things include ethnic predisposition to certain disorders and close biological relationships between parents, like consanguinity. An example would be first cousins. which is not as uncommon as you may think, particularly in certain cultures. The first cousins marry. Well, that increases the risk that recessive traits are going to be more expressed than they would otherwise be. Interest of time for this lecture, and because you have many wonderful resources available to you in the module, I'm not going to go through drawing out a pedigree. But how are you going to do it? You're going to do a patient interview, you're going to take some notes, and from that you can build a pedigree. And there are many family-friendly data collection tools so that you don't have to do it in the course of a visit. You can refer your patients to these online resources where they can essentially do their own pedigree, or at least collect all the information you will need to conduct a pedigree. But again, refer to the Goolsby book, because everything you need is in there. That said, here's a nice example of a pedigree, of how you write a pedigree. What are the common symbols, and how do you write relationships so that you end up with this family tree or pedigree? This comes right out of the textbook. It's a nice depiction. But remember, there's online tools that you fill in like a database that eventually draws the pedigree, and that would be how you would direct your patients, or if they don't have the capacity to do it, you could collect the data you need so that you could create a pedigree for them. Once the pedigree is done, it's going to have to be interpreted. There are single gene disorders, which are a result of an alteration in the gene or a permanent heritable change in a sequence or arrangement of DNA called a mutation, and the mutations show up and they're designated in the pedigree. Mutations that occur along germlines can be passed on to offspring. Germline cells, meaning sex cells. Mutations often result in an alteration or absence of a protein function, which contributes to the pathophysiology and symptoms related to single gene disorders. Because mutations in single gene disorders are inherited in predictable patterns, they are often classified as dominant or recessive, and we've covered this, I think, already enough. Let's look on ahead at the next slide about what are some of these diseases. Again, from the book, really nice chart. So on the left column you see inheritance pattern disorder, autosomal dominant. Autosomal, again, not sex-linked. Dominant, meaning going to be expressed if the gene is present in even one of the parents or one of the chromosomes of a person's chromosome. So because it's autosomal, you're going to have two genes, one from the mother, one from the father. If either of those is mutant, it's going to be expressed because it's dominant. So polycystic kidney disease, the estimated prevalence is 1 in 500 to 1 in 1,000. The clinical features are, well, you know, polycystic kidney disease. It's right there. All of these things can happen as a result of that. Marfan syndrome, the connective tissue disorder, 1 in 10,000. But 25 to 35% of the Marfan syndrome mutations may be de novo, which is high compared to others. Familial hypercholesterolemia, about 1 in 500, and that, of course, leads to cardiovascular disease, and xanthomas are kind of a way to find them when you're doing a physical exam. They don't, in and of themselves, cause much problems. Then you move on to the autosomal recessives, hemochromatosis, high absorption of iron, excessive storage in the liver, skin, pancreas, heart, joints, and testes. Predominant 1 to 200 to 1 to 400 in Northern Europeans, but rare in African Americans at 1 to 7,000. X-linked recessive, the Fragile X disease, and Duchenne muscular dystrophy is examples of it. And then we get to the mitochondrial DNA one, Leber hereditary optic neuropathy. Remember, this is not in the nuclear DNA, but in the mitochondrial DNA. Mitochondrial inherited disorders have a distinct maternal inheritance because at conception, the sperm contains only the nuclear content or chromosomes from the father, while the ovum provides mitochondrial and all the cellular structures, mitochondria for all the cellular structures. Fathers therefore cannot transmit a mitochondrial condition to their offspring. The pedigree of a family with a mitochondrial DNA disorder is unique in that all offspring, regardless of sex, of an affected female will have disease, and none of the offspring from an affected male will have the disease. Because mutations may be present in all mitochondrial, or called homoplasmy, or in some heteroplasmy, the risk and severity of mitochondrial diseases often vary widely among family members. One example of a mitochondrial disorder is the one shown here, the Leber hereditary optic neuropathy. We're going to move now to talk about genetic and genomic testing. First, I would just say the Human Genome Project was an international scientific research project with the goal of determining the base pairs that make up the human DNA and of identifying, mapping, and sequencing all of the genes of the human genome from both a physical and functional standpoint. It started in 1990 and it was completed in 2003. Since 2003, there have been assays or testing methods developed to rapidly and relatively inexpensively identify an individual human's genetic material. The first widely known direct-to-consumer testing was a product known as 23andMe. I imagine you're familiar, at least with the advertising. Many more have become available. Most charge between $100 and $300. These tests reveal things like ancestry, ethnicity, genetic health risks for things like cystic fibrosis or BRCA1, BRCA2, cancer mutations, carrier status for some genetic disorders, physical traits, wellness insights like genetic predisposition to weight gain, sleep patterns, pharmacogenetics. Accuracy and interpretation of these direct-to-consumer tests vary, and there are some significant privacy concerns. Having no professional to interpret and support the disclosing of data can be problematic, and there isn't much regulatory oversight. With a rapidly changing science, it also means that the interpretation of genetic patterns today may change with new science. And these direct-to-consumer tests are not part of a comprehensive health assessment. All said, you should know they're going on. Your patients could come in with data from them, but there are a lot of problems that come from it depending on what people are looking for. On the other hand, let's talk about professional genetic testing. This is a chart I lifted out of UpToDate, but it talks about the typical kinds of professional genetic testing. So in that left column, you'll see diagnostic genetic testing, assessment of the DNA sequence or chromosomal changes or copy number variant, structural alteration used for diagnostic or disease characterization purposes. Carrier screening, prenatal testing, pre-implantation testing, newborn screening, and then, of course, the direct-to-consumer that we've already talked about. Here are some genetic testing key points I would like you to take away. Genetic testing is any type of testing that determines the genotype DNA blueprint in a germline or somatic cell. The testing can involve a single gene, a panel of genes, or the entire genome. For each gene, it is possible to analyze a single variant, a panel of variants, or an entire coding sequence. The purpose of genetic testing is to determine the likelihood or presence of a condition or disease, also said risk, and in some cases, likely response to treatment. Clinical applications cover the lifespan from fetal testing to oncology to pharmacogenomics. They are used to determine whether the test is indicated, the ideal age at which to test, and which test provides useful information with the least cost and burden. Those are the things to be determined. Who are you going to test? At what age should they be tested? And which test should be used? These considerations can be discussed during pretest genetic counseling, which is important. Pretest genetic counseling, and can be that counseling can help patients to understand the implications of a positive or a negative result before they have the test done. Continuing with key points, there are ethical and psychological concerns related to genetic testing, and they include potential consequences for at-risk relatives and the burden, moral burden to warn people. If you find out um, that someone has a significant genetic um, variant or mutation, and it's likely found in their relatives, what is your obligation to make that known? Or what is the patient's obligation to make that known? The inability to obtain informed consent from children is a problem, and fears about genetic discrimination. Initial testing should be performed on an affected individual when possible. Future testing can be tailored for at-risk uh, relatives. Testing can be ordered by any clinician involved in the individual's care who address the appropriate test and the methodology, logistics for test ordering, counseling, and use of results in clinical care. So, to simplify that, generally speaking, primary care providers are not ordering genetic testing. What we order is a referral to genetic counseling, and people who do this all the time in their practice will do this function of ordering the test, explaining it, getting informed consent. That is not something that generalists typically do. So this may include a clinical geneticist, a genetic counselor, primary care provider, disease specialist. Informed consent is a foundation for the voluntary nature of genetic testing. And a final key point, management may involve additional testing or interventions tailored to the disease or the disease risk. So if testing is negative or reveals a variant of uncertain significance, management depends on the estimated likelihood of that disease. Positive results from germline testing generally do not need to be repeated if the results are obtained from a CLIA-certified lab and are considered to be accurate, since germline DNA sequence does not change. More extensive testing, reanalysis, and sequence data or review of new information about pathogenicity might be appropriate, because we're learning more about how to interpret data all the time. So what are the implications for us in advanced practice, for generalists in advanced practice, whether they're acute or primary care? 1. Prediction of risk for adult onset disorders with a known genetic component like familial breast and colorectal cancer, Huntington's disease, is based on family history and or genetic testing. So we need to get that in our history. Assessment of reproductive risk by testing for common autosomal recessive conditions such as hemoglobinopathies, cystic fibrosis, and muscular dystrophy can be done when someone is in particularly infertility work, where we're going to be doing procedures that obviate the natural selection, if you will. I'm thinking of like IVF, where we may be creating zygotes that in nature would not normally survive to the point that they will in the artificial environment. And for those reasons, we are going to do some extensive genetic analysis before we move forward to IVF. Testing for genetic components of common disorders that have multifactorial etiologies, such as ischemic heart disease, asthma, or diabetes, in the patients you find that have red flags, and identifying normal genetic variations that predict drug response and effect and side effect profiles. We aren't going to talk about pharmacogenetics in this course. I'm not going to have not put any content in here. When you get to pharmacology, you will have some content on pharmacogenetics. The information can be very sensitive, and there are certain things that we must consider. For one thing, familial structural issues, paternity, adoption, assisted reproductive technologies, and estranged relationships come up when you're doing a detailed pedigree. And questions get asked sometimes by patients of their families that are uncovering information that has prior to that time been withheld. So they can be sensitive. there can be losses, stigma of health issues, fear of health issues. And because of that, in 2008, there was a bill passed, a law created, Genetic Information Non-Discrimination Act, called GINA. And it does provide some protection against health insurance and employment discrimination because people carry potential factors for future disease in their genome that has not yet been expressed. So if you're a health insurance company, you would like to know who is likely to develop a cancer or heart disease or something based on that genome, and you might choose not to insure those people because they're going to have more claims in the future. For that reason, GINA was created. It doesn't provide perfect coverage, but it was a start. Something that came after GINA, the Affordable Care Act, which put prohibitions about pre-existing conditions as a condition of getting health insurance, has helped a lot, because now that we have the Affordable Care Act with the prohibition against using prior conditions as a reason to not insure, anything discovered in genetic testing technically is a pre-existing condition. So that did help. Let's talk a bit about the ethical, legal, and social implications. So the basic tenets of ethics apply: beneficence, non-maleficence, patient respect, autonomy, and fairness. Issues that often arise in this area are risks, benefits, informed consent, who to screen, when, and what age for testing, and how do you get kids to give informed consent? Can parents do it? That's been a big discussion. Generally speaking, we accept for minors that their parent or guardian can give consent. However, there's some concern that that may not apply to genetic testing because the inherent benefit, which is the reason you do it, why you let minors have their parent or guardian agree to their treatments, is that this isn't a treatment and it isn't a test directly related to a treatment. This is, we don't know what the benefit's going to be. And when we don't know what the benefit's going to be, then it makes consent a much stickier issue. Okay. Protection and privacy of genomic data for the individual. Because the genetic code is shared among family members, there may be some duty to warn considerations. But once we do that, then we've got a privacy problem. So as you can see, this is kind of a sticky wicket. Then pretty well touched on misuse of information by insurers, and stigmatization can occur from simply having associated with the test results if it shows mutations, even though the patient hasn't demonstrated any of those illnesses yet, or may never, but they could pass them on. There is a stigmatization that can occur as a result of having mutations. So, putting it all together, let's try to draw this all into a conclusion. One of the things you should know is time constraints are the biggest demonstrated barrier to collecting a 3-generation family history, especially if you have to go to the level of a pedigree. Recommendation: give patients time to collect their family history before or after the visit, not in the visit. Don't rush it so much you try to squeeze it into your 20 or 30-minute visit. And use the tools available. Many patients have the capability. If you give them the website, they will be able to do this. If not, you may have to sit with them paper and pencil and collect data, but you're going to need some protected time to get a good 3-generation family history in people where you have identified red flags. What are NPs accountable for? To collect a comprehensive family health history as part of an overall health assessment, To identify family members at increased risk for genomic conditions by the red flags. Educate patients, families on genetics and genomics tests and therapies. Provide informed consent, although I would say, if we're talking about testing, I would always have them referred to a specialist in genetic testing for informed consent because I don't work in it all the time. Refer at-risk individuals. I can't say that enough. Refer at-risk individuals if they're willing to go. And continue learning about genetic and genomic assessment as the science develops. So that's the conclusion of the lecture. Here's a bibliography of some of the resources I used in constructing it. I look forward to seeing you in class, and I'd be happy to take your questions then.